All right, let's get straight to it. This is a direct protocol for recognizing and managing phenytoin overdose.
We'll quickly cover 5 key areas: a general overview, clinical presentation, the toxic dose thresholds you need to know, management strategy, and finally, observation and disposition.
So, first up, let's look at what's fundamentally causing the toxicity.
It's pretty straightforward. Toxicity happens because of elevated serum phenytoin levels. This can come from an acute overdose, of course, but also from metabolic issues that mess with the drug's clearance. The good news is that overdoses involving only phenytoin are rarely fatal. Now, here's what makes phenytoin so tricky. It has what we call nonlinear pharmacokinetics. What that means is the body's system for clearing the drug gets saturated or maxed out. So even a tiny increase in the dose can lead to a surprisingly large, unpredictable jump in serum levels, which makes management pretty complex.
So what are you going to see in a patient? Let's talk about the clinical signs and symptoms.
The presentation is almost entirely dominated by central nervous system or CNS symptoms. The big things you'll see are ataxia, which is that unsteady gait and lack of coordination, along with confusion and sedation.
And here's a really important distinction. The intravenous or IV formulation is different. It contains propylene glycol. If you infuse it too quickly, you can cause cardiotoxicity, things like hypotension and arrhythmias. This is a totally separate risk from the CNS effects you see with an oral overdose.
Now for the numbers. Let's cover the specific dose thresholds that you should be aware of.
A key number to remember is 20 milligrams per kilogram. An ingestion at this level is where you'll start to see those cerebellar signs like ataxia begin to appear. This is your marker for mild to moderate toxicity.
Now, for the more severe effects like coma or significant sedation, you're looking at a much larger dose, typically around 100 milligrams per kilogram. But again, it's worth repeating. Deaths from an overdose of only phenytoin are very rare.
Okay, so you have a patient with an overdose. How do you manage them? Let's walk through the treatment strategy.
Management is mainly supportive care. So you start with the ABCs, stabilize their airway, breathing, and circulation. Then get them on continuous vital signs and neurological monitoring. For an acute oral ingestion, if they present within 4 hours, go ahead and give a single dose of activated charcoal.
This naturally leads to the next question. What about multi-dose activated charcoal, or MDAC? When does that come into play?
Multi-dose activated charcoal is something you'd consider for large oral overdoses. The whole goal is to help enhance the elimination of the drug from the body.
But before you give MDAC, you absolutely must make sure there's no ileus. You need to hear bowel sounds. After you give it, you have to continue monitoring their bowel function and keep a close eye out for complications like charcoal regurgitation.
Phenytoin is a sodium channel blocker. This is why you should never give it as an intravenous bolus. It would cause acute sodium channel blockade, like a tricyclic antidepressant, causing widening of the QRS with risk of dysrhythmias, including ventricular tachycardia. Treatment of ventricular dysrhythmias involves sodium bicarbonate 2 millimoles per kilogram intravenously, repeated every 1 to 2 minutes to restore a perfusing rhythm. Multiple doses may be required. Lidocaine 1.5 milligrams per kilogram intravenously may be indicated when the pH is greater than 7.5. If the QRS persists in widening after boluses of sodium bicarbonate, then the patient will require intubation and ventilation to maintain a pH 7.5.
All right, last section. Let's cover observation and the criteria for discharging a patient.
For any patient with a suspected phenytoin overdose, the rule is a minimum observation period of 6 hours after they ingested it. This gives you enough time to see if toxicity is going to develop or worsen.
A patient can be considered for discharge only when they meet 2 key criteria. First, their Glasgow Coma Scale, or GCS, has to be 15, meaning they are fully alert and oriented. Second, they have to be clinically stable, with their symptoms clearly resolving.